Thank you very much, Lori. Again, I wanted to introduce myself. My name is Hank Freeman, and I'm one of the interventional radiologists at JFK Medical Center. As Lori was saying, we have great new equipment at the hospital. Basically, we have 3 interventional suites that are, 2 of them are brand new. Basically, one of them is 2 months old, the other one is maybe 4 months old. State of the line, state of the art, great equipment. And it might not excite, as she was saying, it might not excite you guys, but for people like me, it's really great. Okay, who we are. Basically, the interventional radiology team at JFK comprises 5 physicians. I'm here tonight representing our group, but the procedures that I'm going to be talking about, I do, and basically everyone on our team does the same type of procedure and is trained in the same fashion. Okay, first of all, what is an interventional radiologist? Most people don't know what interventional radiology is. Truthfully, I didn't even know what interventional radiology was until I was a second-year medical student. I was doing some research in pediatrics. I thought I wanted to be a pediatrician. Ended up, the husband of the pediatrician I was working with was an interventional radiologist, and I thought what he was doing was much more interesting, so I ended up learning about it and going into the field. Basically, what an interventional radiologist is a physician that does minimally invasive surgery. We do surgery that's guided by radiology techniques, ultrasound, CAT scan, X-ray, MRIs, all of the different radiology techniques. And what we do is we can see inside the body, and we do procedures or surgical procedures that are guided by those radiology exams, and we can do these procedures through a little nick or a little cut in the skin. That's a picture of an interventional radiology suite, similar to the one we just put in at JFK. What are uterine fibroids? That's what we're going to talk about tonight. It's a benign tumor of the uterine smooth muscle. They are not considered cancerous, even though they do grow like cancer. They do grow like tumors, but they never spread, so they're like confined cancers. Even though I don't even want to really use the term cancer because that scares people off. They're also referred to as leiomyomas or myomas, and there are different types which I will go into detail about. Okay, this is a schematic showing the different types of uterine fibroids. The different types are here. This is a subserosal fibroid, which is on the outside of the uterus. A submucosal fibroid is here on the inside, basically abutting the endometrial lining. And then there are also intramural fibroids, which are just within the muscle layer of the uterus. Different types of fibroids cause different types of symptoms. The submucosal fibroids are the ones that abut the endometrial lining or the lining of the uterus. These are the least common, however, they are the most symptomatic. What happens is when these fibroids or growths, they abut the lining, they cause excessive bleeding, especially during your menses. They can cause problems with infertility. They can cause heavy clots. These are usually the patients that come in and tell me, basically, I am bleeding so much during my menses, I can't leave the house. Other types of fibroids are the subserosal fibroids, which are these ones on the outside. They cause different types of symptoms. Basically, what the subserosal fibroids do is they cause pain. They cause pain because they push on other organs. Like if their fibroids are on the anterior or the front of your uterus, they can push on your bladder. They can cause problems with your bladder. If they push on the back of your uterus, they can push on your rectum, causing constipation. They also cause these vague bulk symptoms, which are just a fullness in your pelvis. Intramural fibroids are the fibroids within the uterine wall, and they can also cause that generalized fullness or bulk symptoms. How common are uterine fibroids? It's estimated that 25 to 50% of all women will develop fibroids over their lifetime. And they're most frequent in the ages of 30s and 40s before you go into menopause. It's the most common tumor of the pelvis, even though they are benign. However, this is an important side note. A minority, only about 10 to 30% are symptomatic. Basically, because these fibroids are so common and because they're benign, the only reason to treat is if they become symptomatic. And what causes these fibroids? Truthfully, we don't really know. We have some suspicions and we do know some reasons why they occur, but we really don't have a good grasp of it. We know that they are linked to estrogen and progesterone. So basically your body's hormones that you secrete during your menses cause these fibroids to grow. What I like to think of it is like almost like the gas line to the fibroids is your estrogen and progesterone that you are producing when you're going through menses. And when you go into menopause, it's almost like we shut that gas line off and the fibroids will shrink. Fibroids may dramatically increase in size during pregnancy. That's usually related to the amount of estrogen and progesterone that are produced during pregnancy. And as I said before, they improve after menopause for the same reasons they increase during pregnancy. As those hormone levels decrease, the fibroids will shrink. What symptoms occur with fibroids? As we were stating before, heavy menstrual bleeding, sometimes with passage of clots. Anemia can occur. I've had many patients come to me saying that their doctor wants them to have this procedure done because their hemoglobin level or their red blood cell count is so low that it becomes almost dangerous. Pain, pressure, feelings of fullness, frequent urination or constipation, depending on if the fibroids push on your urinary bladder or if they push on your rectum. There could be pain during or bleeding after intercourse, infertility, an abnormally enlarged abdomen, and pressure. This is a schematic showing different fibroids. Where they're located really will determine some of the symptoms. For example, this fibroid is pushing on the bladder, it can cause urinary frequency, which is basically the urge to urinate all the time. Basically, if you get up in the middle of the night and have to pee 3, 4, 5 times, that's urinary frequency. It could also, if it's on the back of the uterus, can push on the rectum, causing constipation. So who gets fibroids? They increase with age until menopause, where they do decrease. So approximately 20% of women in their 20s, 40% in their 40s. There is a genetic predisposition, and African American women are definitely at higher risk than Caucasian women or Asian women. It's usually familial, but the exact cause we really don't know. And how are they diagnosed? They're usually diagnosed during a gynecological exam by one's gynecologist. They'll usually note that your uterus is enlarged, and they'll send you for some sort of imaging test. Usually the first step would be an ultrasound. And then a second or a better test would be an MRI. Usually when I do the procedure, I get an MRI on every patient prior to the procedure because you can really see the anatomy perfectly. You see if the fibroids are enhancing. You can see if there are any contraindications to doing the surgery. There also are some different types of diseases, specifically something called adenomyosis, which tends to mimic fibroids. So I tend to rule that out with the MRI. So this is a picture of an MRI unit and an ultrasound. And these are images from an MRI and an ultrasound. And this big black mass right here, this is the fibroid. This is the normal uterus, the endometrial lining. And these are some smaller fibroids. But this one is the one causing most of the symptoms. And in this ultrasound, this big hypoechoic mass right here is a fibroid. They can also be diagnosed using hysteroscopy, which is where the gynecologist will put a scope into the cervix, through the vagina, and you can actually directly visualize the fibroids. And how are they treated? Most are not treated because they're asymptomatic, but the ones that are symptomatic, those tend to be the ones that need to be treated. The first line is usually drug therapy. Usually one's gynecologist will put the patient on oral contraceptives, and sometimes that will alleviate the bleeding or the pressure and control the growth of the fibroids. Non-steroidals such as Tylenol, Aleve, they can help to alleviate the discomfort and pain from fibroids. So I want to talk specifically about a drug called Lupron, which is it's a heavy hormone antagonist, that can help with treatment of fibroids. It's something called a gonadotropin-releasing hormone agonist, which blocks ovarian estrogen production. Basically, what this does is it puts you into a false state of menopause. So it makes your body think you're in menopause, so that your fibroids will decrease in size. However, you do get all of the secondary side effects from menopause, the hot flashes, osteoporosis, possible heart disease. So a lot of people don't like when they're put on Lupron. Mostly it's used for a short time if the surgeon thinks that your fibroids are too big and wants to shrink them prior to surgical procedure. If these hormone therapies and if drug therapies don't work, the next step is a surgical procedure. And these are the different types of surgical procedures, and we'll go into detail on all of them. Okay, a myomectomy, a lot of people probably heard of a myomectomy. That's a surgical procedure where the gynecologist will go in and actually cut the fibroids out. It can be done either through your vagina, which is called hysteroscopy, or it can be done laparoscopically, which is where the doctor will put in small probes through your belly and basically blow up your belly and cut the fibroids out that way. How they do this is through the techniques that we described, and there are a few advantages, disadvantages to this type of a procedure. The advantages are that fertility can be preserved. It's a well-established procedure. And if it's done laparoscopically or hysteroscopically, it's less invasive than a major incision. The disadvantages, the thing that I see a lot is that there is a high recurrence rate. There's at least a 20% recurrence rate. And they usually cannot get all of the fibroids out at one time. If there's one solitary fibroid that's enlarged, they can usually get that one out. But if there are multiple fibroids, this procedure does not work well at all. This is a schematic showing a laparoscopic myomectomy, and this is a schematic showing a hysteroscopic myomectomy, where they go in through the vagina into the cervix and cut out the submucosal fibroid. Endometrial ablation is another procedure. What this is when the gynecologist will go in through the vagina and basically burn, using an ablation technique, burn the endometrial lining. What this does is it will decrease the bleeding. However, it's not really treating the fibroids at all. What it is it treats the symptoms. So if you have heavy bleeding from your fibroids, this will decrease the symptoms, will decrease the bleeding at least for a few months. However, the fibroids are still there and they will come back, and once the endometrium regenerates, the symptoms will come back. There's a newer procedure called HIFU, or high intensity focused ultrasound, that's done in some academic centers. At this point, it's still in clinical trials. It's really not good enough for use in the general public yet. It's a high-focused ultrasound that will heat up the fibroids, and it's usually MR guided. So it's something that I'm excited about, but it's really something that's not ready for prime time yet. Then there is the gold standard, which is a hysterectomy. A hysterectomy is the surgical removal of the uterus. It's the second most common surgical procedure in the country, and it's 100% effective for fibroids. They take out the uterus, they take out the fibroids, sometimes they take out the ovaries as well. It can be done either through the vagina or through a laparoscopy, through an incision in the abdomen, depending on the size of the uterus. The advantages are that it's 100% curative, no risk of future cancer, and it's a well-established procedure. However, there are a lot of disadvantages. It's major surgery. General anesthesia, you're in the hospital for 3, 4, 5 days, and then there's a large recuperation at home, probably about 6 weeks of convalescence. If the ovaries are removed, you automatically go into menopause at that time. And there's an emotional aspect to taking out your uterus for women. And I completely understand that. As I was saying, it's a very, very common procedure, and 90% are done for benign reasons, and the most common reason is fibroids. If your mother or your grandmother had fibroids and were treated, most likely they were treated with this procedure. It's been around for a long time. It's considered an old school common procedure back about 40 or so years ago. In an OBGYN literature, one of the most renowned OBGYNs at the time, Dr. Wright, stated the uterus has but one function, reproduction, After the last planned pregnancy, the uterus becomes a useless bleeding symptom, producing potentially cancer-bearing organ, and therefore should be removed. Obviously, Dr. Wright was not a female. Okay, why not have a hysterectomy? Well, after his rousing endorsement, but there are plenty of reasons not to have a hysterectomy in this age. Avoid surgical adverse events, which can definitely occur with general anesthesia and with major surgery. Pelvic support issues, bladder dysfunction, menopause, sexual dysfunction, and also for an emotional reason, just basically that people don't want to have their uterus removed because it's a sign of their femininity. So now I'm going to go into detail about what I do, and that's a procedure called either a uterine artery embolization or a uterine fibroid embolization. It's done by the interventional radiology team. What we do is we make a small nick in the artery, in the groin, and we use a needle and we puncture the artery in your groin. It's an angiogram. A lot of people know angiograms of the heart for people who have blockages in their heart arteries. It's a similar type procedure, except instead of going to the heart, we go to the arteries that feed the uterus. The catheter, which is like a little tube, is guided through the artery to the uterus. It's guided to the artery that feeds the uterus. And we watch this all under this high-tech real-time X-ray machine. So that's how we see exactly where we're going. Once we get to where we want to be, we inject a little bit of contrast to make sure that we are in the uterine artery. And then we inject these tiny little beads, these gelatin beads that block up the end arteries that feed the uterus. This cuts off the blood flow and will cause the tumors to shrink. Basically, we're stopping the blood supply to the fibroids, essentially causing a fibroid attack. We're starving the fibroid of nutrients and of oxygen, and the fibroid will die. It's done in the angiography suite, which is like an OR with a very fancy X-ray machine. We do it with conscious sedation. I almost always have an anesthesiologist there who will give IV sedation. We don't give general anesthesia, so there's no breathing tube. There's just sedation that will make you feel, it basically will make you sleepy, and you won't really remember anything from the procedure. We monitor you during the procedure. The procedure typically takes about an hour and a half, and I usually keep my patients overnight in the hospital, and they go home the next morning at 8 a.m. Uterine fibroid embolization, it's been around for a long time. It's been around for about 40 years, and where the procedure came from is that we used to do this because of patients who had bleeding after pregnancy. Sometimes the uterus doesn't contract enough, and that postpartum patients are bleeding excessively from their uterus. So we would actually do this procedure as an emergency. And we noticed that the patients who had fibroids did well after the procedure. So we ended up about 20 years ago, maybe 25 years ago, doing this procedure for fibroids. And it's been around ever since, and at this point, it's a well-established procedure. So the expectations for post-procedure, the biggest complaint that I see is that there is a variable amount of pain after the procedure. Because of what we're doing, we're stopping the blood supply to the uterus. Even though the fibroids are something you don't want, they are still part of your body. So when they're dying, they do cause a fair amount of pain. Usually, the amount of pain is relative to the amount of particles I use, which is relative to the size of the fibroids. So if you have a huge fibroid uterus, chances are you'll be on the higher side of the pain spectrum. But if you have a few fibroids that are causing symptoms, you probably will have a minimal amount of pain, or be on the lower side of that pain spectrum. However, I treat everybody like they're going to have a ton of pain, and that's really the reason I keep patients in overnight, just for pain control if they need it. And then I'll give everybody pain medication, whatever they need for that first week. The good thing is that at about 7 days, the pain dissipates. So that first week can be pretty bad. I mean, I'd say about 25% have no pain, about 50% have moderate pain, and about 25% have pretty significant pain. But in everybody, in about a week, it's gone. Fever is an occasional side effect, but it's rare. I really don't ever see it. Many women resume light activities within a day or so. If you don't have any pain, you can resume normal activities except for anything really exertional, the day after the procedure. And I usually tell people not to exercise for at least 72 hours. If you are having pain, then I would say about a week, but if you're lucky enough not to, you can really go back to work within a few days. Studies have shown that at 5 years, about 80% of women who've had uterine artery embolization experience total relief. The procedure is effective for multiple fibroids because we are basically treating the artery that feeds all of the fibroids, not specific fibroids itself. The recurrence of the treated fibroids is very rare. It's basically none. And in one study in which patients were followed for 6 years, no fibroid that had been embolized regrew. The mechanism of action for uterine fibroid embolization is these small particles. What I like to use is something called embospheres, where we inject these little gelatin beads into the arteries that feed the uterus. We starve the fibroids, and eventually the fibroids will die and they will scar down and shrink in size. This is a schematic showing how the procedure works. We puncture the artery in the groin, put a little tube in all the way to the uterine artery. And here we're injecting the small particles, and the small particles preferentially go to the fibroids, stopping the blood supply and causing the fibroids to become ischemic. This is just a little film showing the catheter in good position, the particles being injected, and over time, the fibroid will shrink down in size and the normal uterus will remain unscathed. This is a procedure that I did. This is an image from uterine artery embolization. See how this is done under X-ray. Basically, this is the pelvis, and these are the bones of the pelvis. These are the arteries of the pelvis. And here you can see these big squiggly arteries here, and on this side, those are the uterine arteries which are enlarged. And here you don't see any filling of the uterine arteries in the pelvis. This is after a successful embolization. This is a more magnified view of the same patient. This is an arteriogram showing contrast in the artery feeding a large fibroid right here. And this is the same patient after the procedure. You could kind of make out right here the fibroid, and basically there is no blood supply to that fibroid. Post-procedure care, the next morning we look at the catheter site, make sure that there's no bleeding from that site. Usually keep patients overnight, control their pain. I have a whole cocktail of medications that I give all my patients after the procedure. An outpatient follow-up. We'll follow up with a phone call in about a week, and then in about 3 to 6 months, we want to repeat the MRI, make sure that everything looks okay, that all of the fibroids we treated have basically died and shrunk down. The results, Condoleezza Rice, a very prominent African-American woman, she had fibroids, and she was treated in Washington while she was Secretary of State, or I'm not sure if she was that or National Security Advisor, but she had her fibroids treated by Dr. Spies, who is a well-known interventional radiologist at Georgetown. A couple of frequently asked questions. Will my fertility be affected? Really, the jury is kind of out at this point. Some people can't get pregnant because of their fibroids. So if that's the rationale, then sometimes the uterine artery embolization can improve your chances of being pregnant. However, the embolization particles also do affect the uterus and slightly weaken it. So it makes it less apt to hold a fetus to term. So really, it's kind of unclear if fibroid embolization, some people it makes it a little worse, some people it makes it a little better. Usually, if patients really want to get pregnant, I usually dissuade them from having the procedure. Will my insurance pay for the fibroid embolization? Truthfully, I don't really know. We have a whole staff of people who will answer that question for you, and obviously that will all be taken care of prior to the procedure. The advantages are that it treats all the fibroids simultaneously. It's minimally invasive. Complications are infrequent. Recurrence is rare. The recovery time is a week or less. No scar formation, no blood loss. We do it under conscious sedation rather than general anesthesia, and your uterus can be saved. The disadvantages are that there's about a 10% failure rate. For maybe a little less than that. For bleeding, it's about a 92% success rate. And for the bulk symptoms, which are the generalized fullness, it's about an 85 to 88% success rate. The biggest disadvantage, truthfully, is the pain afterwards, which is almost always self-resolved. Some clinical results that from a bunch of different clinical trials show the amount of patients, so some of these are pretty big. Bleeding percentage, these are percentage of success for bleeding symptoms and for pain bulk symptoms. Some of these are actually pretty old, 95. I mean, the particles that we use today weren't even around in 95 or probably even 2000. So these are a little dated, these numbers. As I was saying before, bleeding rates today are about, success rates are about 92%, and for pelvic pain, about 90%, and for bulk symptoms, about 88%. In summary, uterine artery embolization is a non-surgical procedure that's really been around for 40 years, and it's been used for fibroids for about 20 or 25 years. It's minimally invasive. The recovery is rapid. There are few complications. The treatment specifically targets fibroids. There's no hormones involved, and all of the fibroids are treated regardless of the size. Thank you very much.